This is Dr. Pablo Castañeda, and the following is the review of Pediatric Hip for the purposes of board preparation. We will cover the topics of hip dysplasia, traumatic dislocation of the hip, slipped upper femoral epiphysis, and Legg-Calvé-Perthes disease. We shall start with hip dysplasia. The most common disorder found in human beings, the incidence of dislocation is estimated at 1 in 1,000 live births. However, the incidence of dysplasia is estimated at 1 in 100, but some studies have placed it at 1 in 30 or even higher than this. There are three main types of hip dysplasia, a spectrum of pathology that goes from dysplasia to instability to dislocation. Clinically, these can be thought of as a dysplastic hip which is stable, an unstable hip which is Barlow positive, and a dislocation which typically is Ortolani positive. The four most common risk factors all start with an F. Females are affected almost 5 times more frequently than males. It is more common in the firstborn baby as well as with frank breech birth, since this is a packing issue and the development of the hip is dependent on range of motion in utero. A family history is also very important since there are clearly genetic influences on the condition. Of these four factors, the single highest risk comes from being breech. As far as laterality, approximately 50% of the cases occur on the left side, 30% are bilateral, and 20% are on the right. There are associated conditions with hip dysplasia. Patients with congenital muscular torticollis can have hip dysplasia in approximately 20%. Patients with metatarsus adductus can have this in approximately 10%. Patients with congenital knee dislocation frequently have hip dislocations, but this is also frequently found in the setting of other conditions like arthrogryposis. The imaging study of choice for patients under 6 months of age is an ultrasound. After 6 months of age, typically radiographs are utilized. The standard ultrasonographic examination of the hip should include 2 views. The transverse view is most often used to evaluate stability. 4 millimeters of displacement under stress is the upper limit of normal. Anything more than this should be considered an unstable hip. The coronal view is more of a morphologic view. It is useful to evaluate the shape of the joint. These 3 measurements should be remembered as they are often tested. Bony coverage should be at least 50%. The alpha angle, indicating the shape of the bony acetabulum, should be at least 60 degrees, and the beta angle, indicating the percentage of soft tissue coverage, should be at most 55 degrees. Radiographs are simple to interpret. The acetabular index is measured by first drawing a horizontal line through the triradiate cartilage at the inferior portion of the iliac bone on an AP of the pelvis. Then a line is drawn from the lateral edge of the acetabulum to the medial edge intersecting the horizontal line. This angle is the so-called acetabular index, and it should be no more than 2 standard deviations from the mean for age, and the upper limit of 24 degrees at 24 months is easy to remember. Treatment for hip dysplasia can be broken down into age groups. In general, patients under 6 months of age will be treated with the Pavlik method. Patients between 6 and 12 months of age at the time of presentation will be treated with a closed reduction. And above 12 months, the standard treatment becomes an open reduction. Risk factors for failure of orthotic treatment have been identified. They include beginning treatment after 7 weeks of age, having an initially irreducible hip, that is, a hip that is dislocated but is not Ortolani positive, developing a femoral nerve palsy during treatment, and the use of a static brace. 2 other risk factors that were identified were having the disease on the right side and having a graft type 4 dislocation. The probability of failure of orthotic treatment when none of these risk factors was present was 3%, whereas if 4 or more risk factors were present, there was a 100% probability of failure. A question often tested is how long should a Pavlik harness remain in place if a hip has not reduced, because of the risk of developing so-called Pavlik harness disease, erosion of the posterior lip of the acetabulum. Although this is somewhat controversial, the best evidence says that 4 weeks does not cause any long-term damage or adverse outcome. When surgical treatment is undertaken, the goal is to obtain a stable concentric reduction while avoiding osteonecrosis. In all cases, 3 major factors should be considered: acetabular dysplasia, femoral version, generally excessive anteversion, and capsular laxity. When a closed reduction is done, with or without an adductor tenotomy, the baby should be placed in the so-called human position, with 100 degrees of flexion of the joint, no more than 60 degrees of abduction, as long as the hip is stable within the so-called safe zone, and between 15 and 30 degrees of internal rotation. The cast should be changed at 6 weeks, but is maintained for 3 months. After this, bracing should be utilized until the acetabular dysplasia normalizes. The imaging that should be taken after reduction should be cross-sectional. It has been proven that an X-ray is not sufficient to evaluate reduction. However, the use of ultrasound, CT, or MRI is still somewhat debated. Current evidence points to MRI as the preferred method of choice for evaluating reduction of the hip after a closed reduction. When open reduction is being undertaken, it can be through a medial or anterior approach. Both have their proponents. The intra-articular obstacles to obtaining reduction include the iliopsoas contracture, the capsular constriction and thickening, redundant ligamentum teres, transverse acetabular ligament, and pulvinar tissue. Osteotomies should be considered in patients over 18 months. The most simple kinds are the Salter and Pemberton. The indication is acetabular dysplasia. The difference between these osteotomies is that Salter, triple, and periacetabular osteotomies are what are considered redirectional, whereas Pemberton, Dega, and San Diego are considered reshaping. Anatomically, the difference is that a Salter osteotomy cuts entirely through the iliac bone, whereas the Pemberton is an incomplete cut which hinges at the triradiate cartilage to reshape the acetabulum. The indications for a triple pelvic osteotomy remain the same, acetabular dysplasia, but typically in older patients with more severe acetabular dysplasia. Femoral osteotomies are generally reserved for older patients. A simple shortening osteotomy is almost universally required in patients over 36 months, with the indication being an inability to obtain a safe reduction without undue pressure across the joint. Derotational osteotomies are indicated when there is increased femoral anteversion that will not correct with the amount of growth remaining. Varus-producing osteotomies are rarely, if ever, indicated in typical developmental dysplasia of the hip. A special mention should be made of adolescent or late-onset dysplasia. The single radiographic finding that is associated with early arthritis is a reduced center edge angle, typically less than 20 degrees in skeletally mature patients. This angle is constructed by drawing a line perpendicular to a horizontal line that goes through the center of the femoral head, and a second line drawn to the edge of the acetabulum. The left hip on this X-ray actually shows a negative center edge angle, and again, normal is considered greater than 20 degrees. Less than this has been associated with early degenerative arthritis. In these cases, the most currently widespread technique to correct the dysplasia is the periacetabular osteotomy. This is a complex cut of the iliac, pubic, and ischial bones around the acetabulum with the purpose of redirecting the joint forces to reduce the chances of developing early arthritis. The most common complications after this complex procedure, in order of frequency, are lateral femoral cutaneous nerve injury, blood loss requiring transfusion, over or under correction, Major nerve injury is relatively rare. DVT and wound complications are not unique to this procedure. We shall now talk about traumatic hip dislocation. Although relatively rare, this is more common than fractures of the hip in the pediatric population. Almost all cases are posterior dislocations. In patients less than 10 years of age, this can occur as a result of a low-energy injury, a fall, or typically from sports participation. This is a case of a 10-year-old boy with this isolated injury. It should be noted that the rate of avascular necrosis is significantly increased if it is not reduced within 6 hours, and the typical rate that is quoted is between 3 and 15%. After closed reduction, X-rays should be evaluated carefully for non-concentric reduction, and cross-sectional imaging with either CT or MRI should almost always be performed. Be very wary of identifying posterior wall fragments. A CT shows a fragment interposed within the joint. Surgical exploration is indicated. A posterior approach is typically preferred. Slipped upper femoral epiphysis. This is the most common hip pathology found in adolescents. The incidence is 1 in 10,000. It typically affects boys more than girls, and obesity is a significant risk factor. It occurs between the ages of approximately 12 and 16, which is a phase of rapid growth. The slip typically occurs through the hypertrophic zone of the physis, where there is less extracellular matrix and collagen. Clinical presentation of slipped upper femoral epiphysis typically begins with pain around the distal aspect of the thigh or the knee. Clinically, slipped upper femoral epiphysis has been classified by Loader into stable, where the patient is able to ambulate even if it is with crutches, and unstable, where the patient has so much pain that they are basically bedridden. These actually represent two different diseases, with the unstable slip resembling a type 1 fracture of the femoral head. Radiographically, the Southwick angle should be measured. It should be noted that a normal angle between the epiphysis and the shaft should be between 11 and 13 degrees. If there is more than this, but less than 30 degrees, that is considered a mild slip. Between 30 and 50 is moderate, and greater than 50 is a severe slip. The treatment of stable slipped upper femoral epiphysis in general is in situ fixation with a single screw. This has proven to be effective and safe. However, the complications can still be impingement, avascular necrosis, which is relatively rare, reported in less than 2% in most modern series, slip progression, chondrolysis, which is typically associated with intra-articular penetration of hardware, peri-implant fracture. The question of prophylactic fixation often comes up. It is indicated in very young patients, those less than 10 years of age, with an endocrine or renal disorder, severe obesity, and it tends to be more frequent in males. Prophylactic fixation is not an entirely benign procedure. A recent study reported a 1% complication rate from prophylactic fixation. Radiographically, there are signs that indicate the patient is at a higher risk for a contralateral slip. These include an increased posterior epiphyseal tilt and a decreased superior epiphyseal extension. Unstable slipped upper femoral epiphysis, again, behaves more like a fracture. Patients present with so much pain that they are unable to ambulate. The rate of avascular necrosis is at least 10 times higher than with a stable slip. Most modern series report a rate around 30%. Treatment is slightly more controversial, but capsular decompression should always be performed. Even if in situ fixation is being performed, it should be done with 2 screws. One screw will not maintain stability. Reduction can be attempted, however, this is somewhat controversial. The Parsh technique of an anterior approach has proven to be safe and effective. In recent years, the modified done through a surgical dislocation has also gained popularity. However, these procedures are not without their complications. Risk factors for presenting avascular necrosis are being very young, less than 11 years of age, and having a shorter duration of prodromal symptoms before presenting the unstable slip. Legg-Calvé-Perthes is a relatively rare condition compared to the others we have reviewed, but frequently tested. It consists of an idiopathic avascular necrosis of the proximal femoral epiphysis. The incidence is difficult to determine, but has been set at somewhere between 1 in 10 to 20,000 children. It is most common between the ages of 4 and 8, and boys are affected at least 4 times more frequently than girls. The most widespread classification that dictates treatment decisions is the so-called lateral pillar classification described by Herring. This divides hips into 3 kinds. Type A presents 0% collapse of the lateral pillar. Type B, up to 50%, and Type C, more than 50% collapse. The classification was later modified to include a so-called BC borderline group, as the authors noted that accurate classification could not be made before 6 months of symptoms. In general, the treatment of type A hips is symptomatic only. These hips fare well despite treatment, and treatment should only be symptomatic and maintaining range of motion. Type B hips, with up to 50% collapse, should be treated according to the age at the time of onset. Patients under 8 years of age tend to do well and should be treated with symptomatic treatment and range of motion only. However, patients who are over 8 years of age may not fare as well, and if they are in early stages, are the few patients who will benefit from a surgical intervention, either a femoral or pelvic osteotomy. There is not enough evidence to support one over the other. In type C hips, where there has been more than 50% collapse, treatment does not typically affect outcome. Range of motion should be maintained to avoid early degenerative arthritis. This concludes the high-yield review of pediatric hip topics designed for exam optimization.